All right. So this is the second case that we are going to be presenting. This is a 70-year-old female. She was referred to clinic for anemia. Her hemoglobin was 8 to 9, and she had some thrombocytopenia, mild, approximately 120,000. She had a remote history of breast cancer almost 20 years prior. She was treated with surgery, radiation, and tamoxifen. She did not receive any chemo for her breast cancer. At the time when she presented, because of her cytopenia, she underwent a bone marrow biopsy. And this bone marrow biopsy was consistent with MDS. It was normal cellular, but it had increased this megakaryopoiesis. There was no evidence of carcinoma that was there, given their remote history of the breast cancer. And she had defining cytogenetics with deletion 5q. First, EPO was attempted, but it wasn't very successful, so she was switched to lenalidomide, which was appropriate given her deletion. Shortly after that, she did well on lenalidomide for almost a year. She had another bone marrow that was done, and this time you actually saw that there was a left-shifted granulocytic maturation and increased CD34 blasts. It was a lot of patchy involvement, but now we're starting to look at something that's a little bit more high risk. There's multilineage dysplasia, so 15% involvement of the blasts. Cytogenetics in fish remain deletion 5q. And I'm purposefully withholding the NGS from you because I will defer that to Dr. Albitar. She was appropriately put on more aggressive hypomethylating agent. She had azacitidine with ivosneb. And then in the midst of that, she had a repeat bone marrow to see if she was responding to her therapy. She had decreased erythropoiesis, this megakaryopoiesis, and dysgranulopoiesis with this intervention, persistent deletion 5q, but this time blast count was improved. So she continued on this for quite a long time, and as we often do with these patients, but over time, there was evidence that she might have been progressing once again, and a bone marrow biopsy almost a year later showed hypercellular for age, 50 to 60%, trilineage dysplasia. Now there's evidence of mild reticular fibrosis. There's 20% blasts, and this is consistent now with a leukemia. So she was started on decitabine and venetoclax, but she didn't take it for long. She had improvement somewhat. In the middle of her course, she had, she's had consistent cellularity, 30 to 40% cellularity, so a little bit better with this myelopoiesis, dyserythropoiesis, and atypical megakaryocytes. Blasts were by differential 16%, but she was still consistent with AML, and so the decision was made to switch her to something a little bit more intensive, so she got dose reduced on arubicin and cytarabine, and this is where we are now. So I will stop.
So this is actually her peripheral blood testing, and as you can really see here, there is JAK2 mutations there, but there is also RNX1 mutations in addition to the ASXL and the JAK2 and TET2s, and still, of course, the 5q minus, this is on the peripheral blood. And at the same time, we tested also at very much similar times, a few days difference, the bone marrows, and we see exactly the same mutations. But when we look actually at this is the bone marrows, and I'm showing here the data for the DNA versus the data for the RNA on the bone marrows, and the data for the peripheral blood cells for the DNA and the RNA. So as you can really see here, the variant allele frequency for the actually the JAK2 here, should really highlight the JAK2 here, which is around 42%, and for here it is about for RNA percentage as variant allele frequency, it is similar, almost 46%. So it just give you an idea, it reflecting each other's. In contrast, in peripheral blood, the JAK2 mutation on the DNA was at 44% versus the JAK2 on the RNA is at 72%, and most likely this because it is reflecting the platelets on the peripheral blood, where the RNA coming from the platelets in addition to the cells, and this is what the difference. If we look at the difference between bone marrow, practically molecular flow cytometries, so you can really see CD13 is very high, actually in the peripheral blood, higher than in the bone marrows, and if we look at actually CD34, it's definitely CD34 cells are high in the bone marrow as compared to peripheral blood, but there is increase in CD34 in peripheral blood, so definitely they are circulating. But if you, in principle, the level is not as big as what you see in acute leukemia, not yet. There is a significant increase in FLT3, but there's some increase in actually KIT or CD117 in this particular patient. And you can really see here the 5q deletion in the peripheral blood and in the bone marrow. It's big time deletions, and this is yours.
So, I think that this case is, even though it has aspects of MDS, MPN, I think it was managed very much in an MDS way, which is what we normally do, for sure, with these patients. But, and I think that her presentation was primarily myelodysplasia. It didn't really arise. It's unclear if maybe earlier, depending on her follow-up, she might have had any evidence of an MPN. However, I just wanted to take the opportunity and then just kind of highlight once again those things that we need to improve upon. So I borrowed this from a review paper from Dr. Teferi at the Mayo Clinic. And ultimately, when you have a patient that has now converted to blast phase MPN, really the best thing that you can do for that patient, if possible, is to transplant that patient if they are transplant eligible. I'm not a transplanter. I'm not going to pretend to be one, but even I can recognize when I can't offer much more. And if you have a patient and so the question is, what do we give those patients to improve their outcomes? And again, this is one of those where we probably need to do a lot more work. There's no prospective trials that have really been looking at, comparing different treatment modalities against each other. We have the benefit of actually looking at small trials, that are experience-based. And based on that, we have then an hypomethylating agent. If the patient has an IDH mutation, then the addition of an IDH inhibitor, and trying to get the best response. But it is important to recognize that you do not need to get an optimal response, and you shouldn't spend your time trying to get an optimal response on these patients and then defer transplant to them, because there is no evidence that actually shows that that an improvement in trying to get those peripheral blasts to less than 5% is going to improve outcomes for this population. So this is one of those things that I wanted to have you take away from this discussion. And then the other thing is that for the transplant ineligible, and probably your lady maybe, well, I'm not sure, would have to have a transplanter evaluate her for that, but investigational treatments. And these are things that are, we have a lot of different investigational treatments with targeted therapies that are in the pipeline. And if the patient has greater than 20% blast, you still want to try to get them to get a hypomethylating agent if possible. This is not going to dramatically improve overall survival, but it may give them a better survival than some of the other agents, or hypomethylating agent alone. So that's something to kind of keep in mind. And then based on this, I just wanted to reiterate some of the things that I had said. We don't have anything right now in terms of data to prove that either an intensive or a less intensive chemotherapy by itself is going to secure long-term survival in these patients. It's dismal prognosis once they get to this point. The survival estimates are actually really quite poor. So transplant, if this patient is eligible, transplant again. And you'll never hear me say that ever, so it's important that you hear it from me. So the value of pre-transplant bridging chemotherapy is uncertain in these MPNs that have accelerated or are gone into blast phase. So that's, if you can't get them to an appropriate, if you can't get them to an appropriate response, still try to take them to transplant. Getting an optimum response with the chemotherapy is not necessarily ideal. And finally, just a plea that we need to start incorporating control studies to determine the optimal pre- and post-transplant measures for this particular population, to see what is going to improve their transplant-associated morbidities, which are considerable, they're not trivial, and their post-transplant relapse, which also happens a lot for them. Even though we keep on saying transplant, these patients still have a challenging road even after they are able to secure that transplant.